quickly just introduce the rest of the team. So we actually have our interdisciplinary team here. We have Mary Gotham, and she's our RN nurse. Lucas Morgan is our clinical psychologist, and I think um, Sarah, I'm not sure she's coming, or Chad sometimes comes, but he can't make it today. But okay, great. All right, shall we go? How many people are in the waiting room?
I opened it up. They're all in.
Okay, great. I see everybody coming in. That's great. Hi, everybody. Welcome. So glad you could join us. We're going to give everybody a couple minutes to settle in.
John, as everybody's getting settled in, can you make Karen co-host just in case? Yeah, perfect. Thank you.
Okay, great. All right. Hope everybody's been doing well. Oh, Sarah's here. Okay. Hi, Sarah. Okay, great. Okay, so let's go ahead and get started. Welcome again to our monthly Echo Jerry Clinic. Again, free CME, distance technology, online learning. This is an opportunity for case discussions. We really like it when you guys ask questions and discuss your cases. Any geriatric topic is fine. Challenging cases are even better. That's why we're all here. We are all experts and we see a lot of cases. So we would love to share. So the thing I just want to remind everybody, we are committed to confidentiality. And so if you share your cases, it must be HIPAA compliant. Also, we want to have it a safe learning environment for mutual learning and encouragement. We don't, no question is a dumb question. Also, a reminder that ECHO consultations are not, do not create or otherwise establish provider-patient relationships between the ECHO specialists and the patients who are being presented. Okay, next slide. All right. And in order to receive CMEs, you just have to register, which you've all done in order to get on. And then also towards the end of the session, there will be an evaluation for you to complete, and you can just do that right away. Okay, just a couple of Zoom logistics, which I'm sure you know about, but the main thing here is this chat tool at the bottom left-hand corner. Enter your name and others joining you in the session today if you have other people in the room. And make sure you're on mute when you're not speaking. And of course, we love to hear you when you have something to say. Next slide. Okay, we have our hub team here. That's me. I'm the course director for the Echo Geriatrics Clinic. Sarah Tompkison is here. She's our licensed clinical social work. So thanks for joining us, Sarah. We have Lucas Morgan, who is a clinical psychologist, and he is here as well. And you can wave hi. And we have Mary Gotham, and she is public health nursing. She's retired after many, many years of really long, good practice and experience. And Chad is not with us today, so great. Next slide. Yeah, so today we have a special treat. We have Angela Lowe. She is a geriatric medicine fellow. So she's just finishing up her first year right now at the end of this month. And she is staying on for a second year for, to do more education and teaching and stuff. And so she's going to be presenting one of her fellows talks with us today. And we have with her another guest. We have Nina Guerrero, who is music therapist. She has a doctorate of music therapy, and she's a clinical director and grants manager for Sounding Joy Music Therapy. So yeah, this should be a very interesting and exciting talk, and I hope it generates lots of good ideas and questions. All right, so I'm gonna hand it over to Angela. Dr. Lowe, take it away.
All right, thank you so much, Dr. Wen. Okay, I'm just going to be sharing my screen. Okay, you guys can see the slides okay? Okay, perfect. So good afternoon, everyone. Yeah, thank you for having me today. And today I'll be presenting about music therapy and dementia. So some learning objectives. Hopefully we'll be able to describe music therapy and its benefits for older adults by the end of today. Also to be able to describe different types of music therapy and to be able to describe different uses for musical therapy in adults, such as aiding in behavioral problems, gait impairment, and providing comfort for those under hospice and palliative care. So music therapy is the clinical and evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by a credentialed professional who has completed an approved music therapy program. Music therapists, they assess emotional well-being, physical health, social functioning, communication abilities, and cognitive skills through musical responses. They design music sessions for individuals and groups based on client needs using music improvisation, receptive music listening, songwriting, lyric discussion, music and imagery, music performance, and learning through music. So engaging in music has been shown to facilitate neuroplasticity, positively influencing quality of life and overall functioning. Music is noted to activate cognitive, motor, and speech centers in the brain through accessing shared neural systems. Who can benefit from music therapy? Children, adolescents, adults, and elderly with mental health needs, developmental and learning disabilities, or Alzheimer's disease and other aging-related conditions, substance abuse problems, brain injuries, physical disabilities, acute and chronic pain, and mothers in labor can all benefit from music therapy. So the purposes of music therapy include providing structure and meaningful engagement, enhancing daily living in an individual or group setting, promoting communication and self-expression through singing and active music making, improving mood and increasing energy, encouraging physical movement through active music making, and decreasing stress and agitation through the predictable, pleasurable experiences of music. There are many different settings for music therapy. This includes psychiatric hospitals, rehab facilities, medical hospitals, outpatient clinics, daycare treatment centers, agencies which serve persons with developmental disabilities, also community mental health centers, drug and alcohol programs, and senior centers, nursing homes, hospice programs, correctional facilities, halfway houses, schools, and even private practice. For the 2018 American Music Therapy Association member survey and workforce analysis, the work settings with the highest number of music therapists are actually in geriatric facilities, such as adult daycare, assisted living, nursing homes, and geriatric psychiatric units. Music therapy for older adults living with dementia is described as a holistic approach that relies on individual strengths and needs, positively impacting mood, behavior, cognition, and mobility. It's also a multimodal means of expression, both verbal and nonverbal. It's a sensory stimulation, personally engaging, validating, and comforting. And music therapy is also a source of meaningful experiences between the caregiver and their loved one. The clinical process of music therapy involves the assessment of needs and strengths that can be activated during the process, the designing of a plan to care to support short-term and long-term goals, which may include addressing anxiety, interaction, transitions, relaxation, or physical activity. Also the implementation, such as singing, songwriting, improvisation, or use of moving to music to facilitate the transition from the client room to the dining room for a meal, for example, and continual evaluation of music therapy treatment and its effect on the clients. There can be individual or group music therapy. So in individual music therapy, this involves the assessment and determination of the requirements, abilities, and experiences of that client. And it also includes various activities and content provided according to that client's background and preferences. In group music therapy, it includes treatment factors, cohesion, interactions among members, and experience sharing, which allows the members to receive therapeutic benefits. In addition to individual and group therapy, there's also active and passive music therapy. In active therapy, this involves playing musical instrument, singing, composing music and lyrics, and discussing thoughts and feelings elicited by activities to achieve treatment goals. And in passive music therapy, this includes listening and appreciating music to stimulate the senses and achieve treatment goals. Given all this information about music therapy, I also wanted to discuss how effective it can be in helping patients with BPSD, or behavioral and psychological symptoms of dementia. Unfortunately, most patients with dementia experience BPSD at some point. In longitudinal studies of community-dwelling individuals with dementia, up to 97% are affected by at least one symptom, most commonly depression or apathy, although delusions, agitation, and aberrant motor behavior, such as fidgeting, repetitive behaviors, and wandering, occur in about a third of patients. And as a review, BPSD can include wandering, shadowing, which is when someone is constantly following their caregivers, or night disruptions, agitation and hoarding, aggression, vocal disruption. It can also include psychological symptoms such as anxiety and apathy, depression or depressive mood, hallucination and delusions. And it can be quite distressing for the caregivers and the patients themselves. So what do the studies say? The study from Alzheimer's disease and associated disorders, published in 2008, was a randomized controlled trial with an N of 59 from nursing homes in Italy. Here, they had an experimental group that received 30 music therapy sessions, while the control group received educational support or entertainment activities. They used NPI scores, which are neuropsychiatric inventory scores. This takes into account the severity of different BPSD symptoms. This trial did show a decrease actually in their NPI scores after 4 weeks of music therapy. In Aging Research Reviews in 2013, this systematic review and meta-analysis of random controlled trials, controlled clinical trials, and controlled trials, which are before and after studies without controls, this showed that music therapy influenced BPSD in patients with dementia. The effects of music therapy on anxiety symptoms were moderate, while the effects on depression and behavior were small. The length of the intervention period was found to be associated with the effects of music therapy. In particular, interventions that were more than 3 months strongly decreased anxiety. The effects were small compared to those of non-pharmacological interventions, compared to those of pharmacological interventions, but nevertheless, the findings are promising in providing an alternate management option for BPSD. And then in 2017, there was a systematic review of systematic reviews of non-pharmacologic interventions for BPSD in dementia patients. They identified 38 systematic reviews and 142 primary studies. They had a lot of different types of non-pharmacologic interventions, including sensory stimulation, such as acupressure, aromatherapy, massage touch therapy, light therapy, and sensory garden. Another group of non-pharm interventions included cognitive and emotion-oriented interventions, such as cognitive stimulation, music therapy, dance therapy, Sneslin, which is a multisensory environment, transcutaneous electrical nerve stimulation, reminiscence therapy, validation therapy, and simulated presence therapy, which involves playing a personalized video or audio tape recording of a family member to the person with dementia when he or she is distressed or agitated. The third group of non-pharm intervention they looked at was behavioral management techniques and other therapies such as exercise therapy, animal-assisted therapy, special care unit, which is generally designed to provide a supportive social and physical environment for older adults with a dementia, and dining room environment-based interventions. Overall, they found that music therapy and behavioral management techniques were effective for reducing PTSD. However, the evidence supporting that effectiveness of music therapy was limited by moderate but significant heterogeneity. This is related to the variability of the intervention, such as possibly the type of music, or is it active versus passive involvement, or were they singing versus playing a musical instrument or dancing, and the heterogeneity of the patient population themselves in terms of the severity of dementia and the type of dementia. So this study was published in Aging and Mental Health in 2013, and it was a crossover trial of 42 participants with dementia in nursing homes in Denmark and Norway. Participants were randomized to a sequence of 6 weeks of individual music therapy and 6 weeks of standard care, and they looked at agitation and quality of life as outcomes. The study showed that music therapy reduced agitation with disruptiveness and prevents medication increases in people with dementia. But because it was a small study, it does call for further research with a larger sample. And then in 2019, a study from the Korean Neuropsychiatric Association looked into 10 randomized controlled trials of non-pharmacologic interventions for moderate to severe dementia. In the current study, non-pharm interventions were not effective in reducing the overall BPSD, agitation, or anxiety symptoms. However, in the subgroup analysis, music therapy was found to be effective in reducing the overall BPSD with medium-sized effect. And then with regards to our patients with Parkinson's, a meta-analysis was done in 2011, which looked into music therapy in patients with Parkinson's disease and revealed that music-based movement therapy did show a significant improvement in walking velocity, and thus promising effects for the improvement of gait and gait-related activities in Parkinson's. Per the American Parkinson's Disease Association, music therapy may have a role in helping those with Parkinson's. One technique is known as rhythmic auditory cueing, and this is when rhythm is used to facilitate movement and improve gait. People with Parkinson's disease often note that moving or walking to a rhythm actually helps improve their movement. Employing rhythm to help people with Parkinson's is frequently used by PD rehabilitation experts, and music is a great way to provide that rhythm. With regards to hospice and palliative care in music therapy, one review of literature from 2005 revealed that pain, physical comfort, fatigue and energy, anxiety and relaxation, time and duration of treatment, mood, spirituality, and quality of life were positively affected by music. Unfortunately, even though there are promising benefits of music therapy in hospice patients, there was a national survey published in 2015 that revealed only 6% of hospices employ music therapy staff. So there could be some room for improvement. And so what are the pros and cons of music therapy? I've listed some. So with regards to the pros, there is compelling data that music therapy can help with BPSD. It's non-invasive and it's enjoyable, and there is a potential to limit pharmacologic interventions. Some cons include a barrier of hearing. Many dementia patients may also be hard of hearing, and unfortunately it's not covered by insurance, and there could be a concern for overstimulation by the music. And before I move on to further questions and comments, I actually wanted to share a clip of some music therapy in action. So I'm just going to switch views. And this is from AMTA.
Watch me go.
What we're perhaps most excited about right now is restorative neurology, or the ability to use patterning or to use intervention to recover function in the brain following insult or following damage. As you know, the brain is the one structure of the body that doesn't regenerate individual cells. Well, the degree to which function can be recovered is phenomenal, and we're just tapping in to the extent that we can get recovery following stroke or injury or disease. We hope that music might play a particularly important role in helping those cells and helping the individual learn to interpret the pattern with those cells. So essentially to help the person learn again.
Sing my song. Can you sing it with me? Let me hear you. I believe in music. Yes.
Parkinsonism is sometimes called a kinetic stutter, and in somewhat the same way as stuttering can be helped by music, so Parkinsonism can also be helped by music, basically by giving the person an organization in time for movement and speech which they lack. The power of music, and especially rhythmically emphasized music, with Parkinsonism extends to other motor disorders, such as the athetosis and spasms, and the sort of movement called tardive dyskinesia, which Maureen has. She has all sorts of involuntary movements all over her body, and also affecting her respiration and speech. This makes it very difficult for her to function or to speak coherently, although she's a fine, intelligent woman. But music somehow brings her out of this, or it coheres all the movement, and she's able to sing beautifully. And of course the words are embedded in songs. The first discovery is that she can sing. The task is then to see if we can partly disembed speech from song, maybe get her to speak in a sing-song way, or somehow use this musical feeling to get over the dyskinesia.
I'm going to say, my name is Maureen, but I'm going to sing it to you. And if you could sing it back to me just the same way, okay? My name is Maureen. Ryan. Okay, just like that.
My name is Maureen.
Right. One more time.
My name is
Maureen Ryan. You want to keep going? Okay.
Maureen Ryan.
Very good. Thank you.
I think that embedding this phenomenon in a therapeutic relationship and a personal relationship with a therapist is extremely important. The therapist will get to know the person, the sort of music they like, and their the states of mind and emotions which are there.
Okay. Yeah, I just wanted to include a clip of different examples of music therapy. But that was the end of my presentation. I'm going to open up for further comments or questions that either I or Dr. Guerrero can answer. Thank you so much, everyone.
Great, that's fantastic. Thank you. Love that overview. Anyway, yeah, I'm sure it has raised some thoughts and questions and possibilities in your mind. I'm going to open it up and see who has any questions. Has anybody seen this in action? Go ahead, Sarah.
I just wanted to say that was just a fantastic presentation. We do know that with people that are living with dementia, the first thing they start to lose is language, and the last thing they retain is rhythm. poetry and prayer. So it made perfect sense that you talk about the benefits and value of music. I just wanted to add that here locally, what's really important is to choose music that's appropriate to that individual's past, whether it's some music from their era or cultural. Like where there was a time I used music to celebrate Bon dance. And the Bon dance allowed people to not only sing the songs, but use rhythmic instruments. But that's perfect engagement.
I'd love to add to that, if I may. I feel that that is such a central aspect of music therapy, that it draws upon the healing and empowering potential of music as a cultural resource, right? It's not something prescriptive that can be measured out in standard doses, but it's part of the living, breathing traditions and values and stories, histories of the multiple intersecting cultures and identities that we all bring with us, right? So music as a cultural resource, music as community building. And so music therapy is inherently collaborative. I think Dr. Lowe chose some great examples of video clips, and you can see that, especially when we're working in groups, that because of the collaborative nature of the process, both between client and therapist and among clients in a group, and there are circles of care as well who may be involved in the process, that it's really about relationships, right? Using music as the medium for restoring healthy relationships, enhancing existing relationships, and forging new connections. And I think music therapists rely heavily upon improvisation. And just to share my personal experience, so I've been working in the field for almost 25 years now, and my very first adult fieldwork placement was at the Jewish Home and Hospital in New York City in Morningside Heights. And what was most exciting to me personally was that elderly clients who seemed to be very isolated within themselves normally, and it would be hard to evoke a response just through, typical verbal overtures like, "Good morning, Mrs. So-and-so," right? But when you brought forth, as Sarah mentioned, music that was resonant with the individual's cultural context, their personal, familial history, then this whole world opened up and was accessible. And what was so exciting to me was it was not just long buried memories. It's almost commonplace knowledge that people who can barely say their own name can somehow sing all 5 verses of "Let Me Call You Sweetheart," or something that they knew in their young adulthood or their youth. But beyond that, it's possible to forge new connections by accessing creativity through improvising music collaboratively with clients in the here and now, in those styles. If you are using styles of music, whatever it may be, Native Hawaiian or Pacific Islander music, Japanese, Filipino traditions, depending on the unique cultural context that you're in, improvising in those styles can allow new connections, new memories actually to be formed through this working relationship. So I just wanted to, really provide the testimony of experience as a working music therapist.
So thank you so much. A really interesting presentation, and also testimony and sharing your experiences. So again, and a question about like if one did not have the knowledge of the different cultural music, you know, what recommendations would you have for like, where would you consult, or are there repositories of music that you could access that are relevant to different communities? I guess, how would you go about that?
So that is actually a vital part of a music therapist training, is cultivating musical resources, learning all kinds of repertoire, whether it's different styles and genres of music, different musical techniques of composition, of improvisation. And what I want to emphasize is that it relies upon a moment-to-moment process of assessment. So the therapy itself is a continual process of assessment in which all of the individual's responses are being taken into account. So even, you know, Dr. Lowe mentioned the distinction between active and passive music therapy. Even when it may be considered passive, we are still trying to engage the responses of the individual to the fullest possible extent. For example, in music therapy in the NICU, or music therapy with one who is immobilized in bed, perhaps in a coma or a state of minimal consciousness. Sure, they cannot vocalize with intent or apparent intent. They can't play an instrument or move in rhythm, but there may be changes in their breathing, in their facial expressions, maybe their pattern of eye blinking, eye gaze. So it's always a process of trying to evoke communication, dialogue, and to be as interresponsive as possible. And that also, you know, speaks to the concerns that Dr. Lowe noted about the possibility of overstimulation for some individuals with music. If the music therapist is properly sensitive and responsive to the responses that they are eliciting from the individual or the group. You know, just like any other form of treatment, it can be calibrated, right? You know, to the extent you mentioned also, Dr. Lowe, the concerns about hearing, right? So hearing is a spectrum, and I wanted to point out that hearing of music is much more robust, of patterns in music, than hearing of speech, for example. And the acoustics of speech are really the first to go in the sensorineural hearing loss that is typical of aging. So the very high, you know, the high frequencies of the consonant sounds are way beyond the highest notes on a piano. And music, it has been said and shown, is a capacity of the mind and the emotions, and not just of the auditory system. Yeah.
I had a question. I was wondering, so I can see that if you're doing the therapy in that moment, you can watch their response. How long does the effect last, say? So, I mean, because the music therapist can be there 24/7, right? Or all their waking hours. Can you comment on that?
Yeah, so this really reflects the importance of the necessity of interdisciplinary collaboration. So the most fruitful work for a music therapist, and I believe for a practitioner in any field, is done in collaboration with the other specialties that are involved in the care of the individuals. So if we are working, as we do, most of our practice at Sounding Joy actually is with kupuna in these various community settings. So it's important for us to be in continual communication with the staff there, the people who know the clients, and are with them, in relationship with them on a daily basis, and can kind of fill us in and be part of that conversation about changing circumstances in the client's life. We went into a setting recently, and there was a couple who were both part of a music therapy group that we were doing at a long-term residential facility for seniors. And we came back the following week, and the husband of the couple had passed away. And from then on, it was really a process of, engaging the wife, but also in the context of the group and all of the people who were providing support. So that's another important point. I mean, a lot of it really shows that well-being is a holistic and integrative phenomenon, right? We may be trying to work on specific physical rehabilitation goals or cognitive behavioral outcomes that we're going for, but it's all in the context of overall well-being, and that is always being assessed.
So it's trying to schedule like physical therapy with musical therapy would be something you would encourage.
Yes, actually, to the extent that we can do co-treatment. So not just relying on the incomplete reports and our, fragmented memories between one session and another, but actually being in a session together. Yeah, that is where you really will see the synergy, that can happen. And I have had opportunities to do co-treatment, for example, with occupational therapists working with stroke survivors. And it's very powerful because, we can optimize the potential of both disciplines. So we can have the OT directing physical movements supported by improvised music. So different from recorded music, yeah, where, it's the same tempo, no matter how the different people in the group or no matter how the individual over time is doing. If you have a live, improvised musical accompaniment by, a credentialed music therapist, you can really meet the needs, support the qualities of movement that you're working toward. And then when it comes to working on movement within instrument playing, the OT can be so helpful in suggesting adaptations. If someone is not able to grasp a mallet like this, they can either, use a bandage to secure the mallet within the hand, or they can coach the person, encourage the person to respond with their whole body. So use the strong side to facilitate movement of the impaired side, and really through the holistic response, the pervasive rhythm that moves the body, the motivation, I think, becomes the key to progress.
Go ahead, Jacqueline.
Oops. Hi, everybody. So I'm a social worker, work in a nursing home, and it always mystifies me to see residents with, I would say, moderate dementia who needs assistance in all their activities of daily living, yet can play the piano beautifully or the ukulele with lots of really beautiful Hawaiian songs. It just baffles me totally, which makes me think that there's a special part of the brain that's reserved for music. Has anybody, Dr. Lowe or Nina or Lucas, has anybody done study on, is it true? Is it a certain part of the brain that's untouched by dementia?
So I will also turn it to Dr. Lowe, but I have read studies of functional imaging that have shown that rather than a special, isolated part of the brain that is specific to the musical response, what is unique about the musical response is that it integrates the functioning across many different systems. So, the auditory, visual, tactile, kinesthetic, cognitive processing, the sequencing that is so inherent in the intricate structure of music, the motor response, and of course the emotions and the drive to connect socially and the access to memory, all have been shown to, somehow uh, be activated together in
Here,
an
you can listen to the
integrative
end.
way.
That's the end part of it, I guess.
Yeah.
Yeah, I don't have too much to add, but yeah, from what I've been reading, there had been studies where they try to, you know, do brain imaging to see what parts of the brain lights up when they, expose their participants to music. And there just have been multiple pathways that are impacted when someone's listening to music. Um, One of the slides earlier had a picture of different pathways, and there they listed, the auditory limbic pathways affected the somatic motor system. The autonomic system also is impacted, and then there's this acoustically activated vestibular pathway. So many different parts of the brain are actually impacted when someone's interacting with music.
Yeah, and that's the key when someone is engaged as interactively as possible in music. So I think that it's interesting to see how many of the capacities that make us human are activated and integrated by musical engagement, right? I mean, it's a very, I believe that the integrative nature of the response is why music is such a robust modality of therapy. I wanted to point out too that, yes, music therapy has all these, clinical applications for specialized clinical populations, but everyone can benefit. So, even people who are, for example, high functioning verbally, cognitively, there are some places that words simply cannot go, right? And in fact, words can act as a defense. People who are so-called high functioning can be highly defended through their verbal, formulas that they repeat to themselves. And creative modalities such as music or art or dance can bypass many of those defenses and open up new possibilities.
So I wonder if I could take one step further. There's been a lot of presentation and study about how to prevent dementia and what you have to do, stay engaged, stay healthy, a healthy heart, healthy brain, et cetera, et cetera. And if it's been shown that music really lights up so many parts of the brain, it would make sense to say if you are engaged in music in some ways, it will be in a way helping your brain stay healthy.
The US Congress would agree with you. Actually, in 1991, there was a special hearing that was called Forever Young. And, the US Congress actually voted to recommend music therapy as one of the mandatory services that must be provided at various community facilities serving older adults. Unfortunately, speaking of just Hawaii's case, it can be difficult to implement this if on the state level there is not official recognition of music therapy as a profession. Many of the people who most need and could benefit most from the services have limited ability to fund it privately. And so, one question that often arises is this covered by insurance? And no, neither public nor private insurance routinely covers music therapy. There are some states in this country where music therapy is licensed either on its own or as part of, for example, in New York, where I did my training, music therapists could become licensed creative arts therapists, and that was a recognized mental health profession, just like a licensed mental health counselor or a licensed marriage and family therapist, etc. And in fact, it's so crucial for Hawaii, I believe, because we have the most rapidly aging state in the nation, according to the Hawaii State Plan on Aging that was put forth in 2019. And I think maintaining cognitive reserves through engagement in cultural resources such as music, I think is such a crucial way to prevent these various processes, right, of dementia and of isolation.
I see Naomi Morita's here with. I wonder if you can have any perspective from hospice point of view that you might want to share.
Oh, this is Naomi. Hold on.
Yeah, yeah. Sorry to put you on the spot. I was just noting you were here.
Okay. Yeah. Hi. Wait, hold on. So I personally don't know if, well, let's just put it this way. One of the social workers, I know for sure, uses music therapy regularly with the patients, and it's really fun. I walked in on some of those visits, and the patients really enjoy that, and it can soothe them. So I mean, this is just anecdotally, but so it's not a regimen that they formally use. But I think it's a great idea, and certainly use it. I've seen it in long-term care facilities, and also in the community, right? Just for our own experiences, we see that. And hey, it works on me too, by the way. You know, it can calm me down in the worst of times, right? So, you know, if it's really agitating, I'm gonna have some calm music. So, I mean, it works for all of us, really. I don't know, did you wanna have any other specifics?
No, that's good. I just
Nothing,
also, want to mention that, you know, I've noticed that in the nursing home, like when we have our sort of namaste programs and things like that, if we catch them like early in the morning or whatever, right, you sort of have this, even after that's done and they leave the room, there's this carryover effect where they're just happy. And so then they're like, for the next 4 hours, they're just good, you know, so.
Yeah, I wanted to add to that, Dr. Wen, that, you know, thinking more about your question about the lasting effects of music therapy. So, you know, they can be difficult to quantify because they are so inextricable from the relationships that are involved, right? If you remember that definition by the AMTA of music therapy, the relationships, the therapeutic relationships are a central part of how music therapy works. And so, you know, even if someone, you know, may not be able to articulate, you know, what songs they sang that morning or what musical activities they engaged in, you know, over time, I do feel that you notice a strengthening of relationships, a feeling of camaraderie and of support. So, you know, one, for example, in working with the Parkinson's community, you know, we have had groups for people with Parkinson's together with their care partners. And when you have them together in a group, you know, you can really see that what lasts over time are the relationships that are formed, the mutual support that is exchanged. And for the care partners as well, very essential. I think also in hospice, I worked at the Queen's Medical Center on the behavioral health team there for several years before coming to Sounding Joy. And in the, you know, cases of hospice care that we were involved in, I really saw that a lot of the benefit was to the family as a whole. And really, that is the, you know, the appropriate level, I feel, you know, to be using these forms of therapy, right, that draw upon the family history, the cultural traditions, the, you know, potential for life review that they can all engage in together.
Seems like, though, I mean, the things that are being discussed is really applicable to everybody, right? I mean, we are united by song in festivals. We are united by song. Hey, you know, you know what, the high school song or the college song. I mean, they unite our communities in different ways, or, you know, it unites us in, you know, a certain era, right? So it just, it's applicable to all stages of life, including on, when they're demented and don't have the same, intact faculties. So,
Yeah, absolutely.
but anyways, I think it's a great idea. Yeah. It should become formalized, I think, right? It should be a formalized thing for, so, I mean, as you questioned, Ida, about the, long-term care facilities, hospice facilities, or even hospice, in the homes, things like that. It would be a nice thing to have regimented. I don't know what kind of, is this an OT thing, and Nina Guerrero, or is it?
No, so it is a profession in its own right. There are uh, accredited university training programs, at various levels, and there's a clinical internship, a 1,200-hour clinical internship under the supervision of a board-certified music therapist, and in some states there is state licensure as well. So it's a distinct profession, but it does have a lot of common ground with other, similar professions, rehabilitation professions, mental health professions, and collaboration is the key.
We certainly don't hear enough about it, right?
Nina, I
Thank
have
you.
a question for you too. This is Sarah.
Yes.
Have you found in your practice that you can, maybe you've tried to introduce intergenerational music? Like I recently was trying BTS with some of people, and it was crazy. It was crazy how they started moving their bodies.
Yes, absolutely. So, when I spoke of working with an individual's circles of care, whether that's, their immediate family, their extended family, the children, the grandchildren, the music that's resonant for each of those generations, of course, will be quite unique. And I think there is so much to be gained by fostering that sense of sharing among the generations. I do feel that, the music of, more recent generations are, have a lot to offer, actually, the kinds of, rhythmic momentum, and when you think about rap, for example, the ability to integrate verbal exploration with rhythm, that kind of thing. I really think that all of the styles are so potentially therapeutic.
Any other comments or questions?
I guess the last question would be, have you found any particular music of benefit for people that are dealing with the phenomenon of sundowning?
Wow, yeah, sundowning is such a challenge, right? I completely agree. And I would have to say that, again, music therapy is non-prescriptive, so it really, really depends on the musical background, and also the kind of just personal, response patterns of the individual. So it relies on a process of continual assessment. So sometimes the music that you and I might consider to be soothing, inducing tranquility, can actually have the opposite effect depending on the individual. My mother-in-law, just to take a random example, has always said that she finds that classical music makes her nervous, right? So forget about the Mozart effect or whatever you might have heard. It is so individualized. Yeah, but what the key is to be mindful of the overall level of stimulation in the environment. So, when you're presenting music, is it, what is the quality of the music? Is it through a tinny little, speaker where it would be more irritating than anything else? Does it have a good range of frequencies? Is the overall, think about the multiple senses as well, the lighting in the room, the, traffic of people coming in and out. I think with sundowning, the overall environment is very important.
Yeah, that's a good suggestion. I know some facilities, Aida, use it's a sound system called Eversound. Have you heard of that, Nina? The
Yes, I
Eversound
believe
system?
so. Yeah, and
Could
it's
you
it's
share
kind
what
of
you've
piped
heard?
in. Yeah,
Right,
it's
and
images along with music. Yes.
right, and then it's an individual headset for each
Mm.
person to wear, so that for people that might have some challenges with hearing, you know, or just focusing, they can block out all the other things, but they can hear music. You can even pipe in music for that specific person, because not everybody, as you said, you know, music is such a personal experience.
Yeah.
What I like in terms of Elvis Presley may not be what the
Yeah.
next person likes.
Absolutely. Yeah.
Great. No, this is just great. I just want to make sure that the link goes in the chat box for evaluation so that people can get CMEs afterwards. So if John, if you could put that in there, that would be great. And yeah, anything else? So how optimistic are you about Hawaii potentially being able to I don't know, pay for music therapy for our seniors?
So right before the pandemic broke out, we were making significant strides, our organization, in terms of meeting with representatives to introduce a bill. So even before the bill for licensure is considered, there is something called a sunrise analysis that has to be done to show that it's even worth investigating whether music therapy should be licensed. And you know, the whole process looked very promising. The representatives were enthusiastic. Unfortunately, when COVID hit, everything was kind of suspended. So, you know, we will hopefully, in an upcoming 2-year cycle, be able to reinitiate the process and hopefully see it through to completion. We're working closely with a task force of the AMTA, the American Music Therapy Association. And I would recommend that if anyone is interested in learning more about the music therapy profession, that you visit the AMTA website. It's simply musictherapy.org. And there you can learn about music therapy research with different populations. You know, you can see some of the peer-reviewed journals in the field or in other fields that deal with music therapy topics.
Thank you so much. We look forward to hearing more, and hopefully this thing will eventually become, you know, reimbursable and a service that, you know, we can really offer more widely to our residents and patients that we care for.
Yeah,
Thank you
I mean,
so-
I think the access is so important, right? Creative arts therapies such as music therapy, art therapy, etc., are largely about equitable access to therapy for people who perhaps may not be able to engage in traditional verbal psychotherapy. This is still a means of communication and interaction. So it is very much about access.
Great. Thank you so much. Okay.
Thank
See
you.
you next month.